So we'll have our keynote speaker for the ending of our conference on opioid prices and the dynamics of public health. We have Casey Mulligan, professor at Chicago.
Yeah, thanks for including me in this. Very glad to be here. And I put together a few slides there combining a few different papers. I'm going to take the parts of those papers that are related to really the title, The Dynamics of Public Health. Here's a kind of macroeconomics picture. This is life expectancy, and I call it macroeconomics because every person in the United States contributes to the number for the given year. So we're not focusing on just high school dropouts or anything like that. That's the whole country goes into this picture. And life expectancy has been growing for a long time. This goes back to 1980. You could take it back almost to 1880, and life expectancy just increasing. Some people would argue pretty convincingly that most economic growth is related to this life expectancy. We have other kinds of growth. The growth shows up in other ways other than being able to live longer, but being able to live longer is a very valuable thing. But what we've seen, the trend stop, even reversed. This is before COVID. If we have time, we can talk a little bit what happened during COVID and afterward. But before COVID, it stopped and headed down. And by the onset of COVID, we're already down about a year or so from the prior trend. And it's commonly understood that this change has an awful lot to do with the opioid epidemic. Unusual number of deaths from poisoning by opioids. So I want to try to investigate this today from the perspective of increasing returns. And increasing returns, it can explain quite a bit about what's going on with opioids. I'm going to focus on three things. One, why the time series kind of looks like an epidemic. Not saying that there's contagious factors in here, although there may be, but that's not going to be the point. But it's going to follow the kind of epidemic dynamics, where there's slow growth, and then all of a sudden a period of very rapid growth, and then maybe slow growth again. The second point we get out of increasing returns is that the demand curve for opioids is going to appear to slope the wrong way. I want to emphasize appear. I'll show you. I'm not saying that there's kind of strange demand behavior here, but it will appear that when you raise a price of at least some of the opioids, that the consumption increases. Then I'm going to show there's a corollary to that, which is that the race gap in opioid mortality would change sign. So at one point in time, one race tends to die more from opioids, and then very soon thereafter, the roles reverse, and that race that was having more deaths has less. And then the third point I will mention today is why the fatality rates for youth and adults, they follow each other for a while and then they diverge. It goes down for the youth and increases for the adults. And all these three things I think can be understood in terms of one economic idea, which is increasing returns. Okay, so I'm going to set up the demand model here. And in my model, there are two sources of opioids. One called prescription. It's coming from pharmacies and pharmaceutical companies. It's kind of in the previous talk we heard about that sector, if you will. And then the other sector is going to be illicit manufacturers. So the pharmacies won't be involved. What you would consider the pharmaceutical companies won't be involved. These will be illicit criminals, if you want, and especially it's heroin and illicit fentanyl. Some of the pharmaceutical companies do make fentanyl for hospitals, but what we're going to talk about is made by really criminals. Now I'm going to differentiate these two sources really on the cost side of things rather than on preferences. You could do that and be kind of a similar analysis, but I think it's a little simpler to think of it from the cost side. So I'm going to start by drawing the picture just saying, well, I said there are two sources, but what if you just had one source? Well, when we have a very Econ 101 type of picture, well, if you can just source opioids from prescriptions, then you're going to have a budget set that looks like this. It's a straight line because there's some price at which you can purchase opioids through the pharmacies. Now I'm going to bring in the second potential source, the illicit sector, and there's going to be a fixed cost to sourcing from there. Maybe euphemistically I'd say that these are things like self-dosing skills. When you go to the pharmacy, the pharmacist tells you how much to take, is measured the pill at a certain size, and so on. In the illicit sector, first of all, some of these opioids be very powerful, so you're dealing in very, very small doses, and you need to, as a consumer, figure out how to dose that because you're not going to have a doctor there to help you. Using needles, taking this intravenously, that's something that's scary to most people at first, but then you get used to it. So that's, again, an example of a fixed cost. But then once you've incurred the fixed cost, maybe, depending on how the prices prevail in the market, the illicit may be cheaper at the margin. And that's the case I've drawn here. And then you get this kind of budget set that has these kind of two parts to it, the red part and the black part. So now you think about choices, and I'm going to put in some preferences here, difference curve for the consumer between opioids and other goods. And I've drawn it so that, well, this consumer might prefer the point like B, where he's sourcing the opioids from pharmacy, and the amount chosen you can see in the picture. Now what would happen for the person who's chosen the point B, what would be his response if we increase the price of prescription? So that's the thing he's buying. We're going to make it more expensive. What's going to happen? Well, we rotate the budget set in the direction of, well, this pharmacy is less affordable, and then he jumps to point C, and point C has more opioids rather than less. Because now and it's not that he's better off, and I don't mean that, I mean that in the economic sense, also maybe the medical sense. It's not that he's better off. We prefer to be able to have that option B that he had before, but by making prescriptions more expensive, option B's disappeared. And his next best choice is option C, which is more opioids. So this is a case where we have a price of opioids, particularly the one he was paying, goes up, and he ends up buying more. Of a different type, but buying more. Now here, this is the same picture. I've taken the preferences away. I used the phrase increasing returns before. I want to show you where I'm getting that phrase from. You can see there's a critical quantity here, Q star, where for whatever reason, maybe it's in difference curves or some other source, the person wants to buy less than Q star, well then prescription is going to be its best choice. It's going to be the cheapest way to buy any amount less than Q star. It's cheaper to buy it through prescriptions. If he wants to buy more than Q star, then his best choice is illicit manufactured, which is cheaper at the margin. So here we have a situation where the more you want to buy, the cheaper it will be at the margin. That's why I refer to it as increasing returns, and it's kind of backwards from what we see in a lot of markets. A lot of markets, the more you buy doesn't affect the price at all. You're free to buy as much as or as little as you want at the price. Other markets may, and it also will be kind of familiar, well, the more you buy, the more expensive it's going to get. In this case, it gets cheaper at the margin the more you buy. That's really the increasing returns. And that's an important enough idea that I want to redraw this picture. I've drawn it in a commodity space, Q opioids versus quantity of all other goods. I want to change it to a kind of Q versus P sort of picture. So I'm going to change that vertical axis to be price or marginal cost. I'm drawing the same picture. And again, we have the Q star. And in this picture, you can see more easily, oh yeah, if you're below Q star, you have a high marginal cost. When you're above Q star, you have a low marginal cost. So this is, you might say, a supply curve to an individual. Maybe also look like this at the market level, but to an individual where the price is lower for the larger quantities. So that's where we're going to get some of the kind of surprising implications when you have a supply curve sloping down. Normally, students, any students who are here, you take an economics exam, draw your supply curve sloping up. If you're just guessing, draw the supply curve sloping up, demand curve sloping down, you'll do pretty well. But not on this one. This one you would be wrong because the supply curve, the marginal cost curve slopes down. So now let me show you the increasing, how you can get the nonlinear dynamics in this sort of picture. Now something's going to have to be happening over time. We could talk about cost changing over time. We'll get to that. This picture is a little easier to draw if we think about demand changing over time. But the demand's changing steadily. Of course, I could have nonlinear dynamics if I just said, well, demand shifts in a nonlinear way. It's shifting slowly, then it's shifting a lot, and then it's shifting slowly again. And I say, no, demand's always shifting in a very steady way. But nonetheless, the behavior won't be steady. It'll be nonlinear. So at first, when people are on their prescriptions and their demand's going up, well, a little shift in demand gives you a little increase in quantity. No surprise there. But then the next little shift in demand gives you a huge increase in quantity because it causes you to change sources. So then you get this middle phase where the same old small shifts in demand now are resulting in big changes in the quantity. And then you could have a later phase, which I haven't drawn in this, where demand continues to march out, and then you're out along the lower curve. And then, again, small changes in demand result in small changes in quantity. So you have this nonlinear dynamics when you have increasing returns. Okay, so let's look at some price information. There's one other thing I wanted to mention. In this picture, the other thing we can look at towards, if we have people who have different levels of demand, we can see that they're going to be in different positions here. So later when I talk about young versus old, I'm going to think about the young having demand curve tends to be more to the left, and the older people having demand curve tends to be more to the right. So they're going to respond differently to these different changes, particularly in prices. Even though they're similar in a lot of ways, the fact that these kind of two sources of consuming can make the groups behave very differently. Okay, so now I promised some price data. I want to show you some price information. Over time, the horizontal axis is year, clearly. The vertical axis is going to be price index. So 100 will be kind of the benchmark spot. But notice I've drawn us this vertical axis on a log scale. We're going to talk about some massive price changes. So the scale here goes from 1 to 100. Very big changes. To give you just a warm-up, this has nothing to do with opioids, but I just show you a series maybe you're familiar with. Boys apparel, boys clothing. It's gotten a lot cheaper over the lifetime, over my lifetime. The clothes that I buy for my kids are a lot cheaper than my parents had to buy for me or my grandparents had to buy for my parents. You can see now you can buy, most recent years, you can buy about 2.5 times as much clothing for the same real income than you could in 1980. That's quite a big price change, and we're all kind of aware of that change. Here's another big one. Again, it's not opioids yet. factor of 100 change in TVs, televisions. Now we have televisions everywhere, right? People have television in their bathroom. When I was a kid, you couldn't imagine, did somebody have a television in the bathroom? I mean, maybe the Queen of England would have that, but now it's very common because TVs have become quality. This is a quality adjusted measure, but TVs have become very, very cheap. Now let me show you illicit opioids. And these are quality adjusted in the sense of per morphine gram equivalent, so the sensation you get when you take it, how much do you have to pay to get that sensation? It's going down quite a bit over this time period, starting around 100, ending around 8. So it's a very big change, bigger than the boys' apparel, although not as big as the TVs. But an order of magnitude change in the prices. It's interesting by itself as economists, we say, wow, something gets an order of magnitude cheaper, maybe people will consume an order of magnitude more, or something like that. We shouldn't be surprised when that happens. I'm going to focus on the later period here. There's a couple different phases, and lots of room for dissertations and senior theses to be written here on this earlier period, from the 90 to 2000, what happened? How did illicit opioids get cheaper? It's not really been studied. You guys live in Texas, you probably got some idea of what might have happened here. You're not allowed to talk about it. But it would be
what's the price of the prescription opioids in terms of cost?
Well, I'm going to show you that one next.
Okay.
We're coming to that. We don't have it for such a long time period.
Okay.
But I'm going to focus on this later period where there's quite a big change, about a factor of 3 toward the end there that I've circled. So even bigger than the boys' clothing did over decades, we had it in a few years. Here's the prescriptions. And this is measured from the consumer side. So the big thing happening here is that the government started paying for opioids. We had the creation of a Medicare program, Medicare Part D. Used to be Medicare didn't pay for pills, but starting in 2006, they started paying for pills. And the government pays for most of it, and the patient pays just a fraction. So that's the main thing. There are also some patents that expired during this period, so that also reduced the prices of some of these prescriptions. That's also a pretty big change, factor of 5 change in prescriptions. Now, all these series are based on pecuniary costs. There's also a non-pecuniary side, which I think is particularly important for prescriptions. In fact, a big part of the regulation has been the point is to increase the non-pecuniary cost of getting opioids. So they're going to try to throw regulations in your way, in your doctor's way, to make it harder to get opioids. And that's not reflected in this series. So I think if you were able to make a series like that, it would come down by this factor of 5, but in the last 8 years or so, it would be coming back up. Okay, so a lot going on with prices. Now I want to look at the same demand curve. I like to economize on stuff, so I got one idea. I'm going to draw it a bunch of different ways. But just economize on the idea. Here I'm drawing the quantity of opioids versus just the prescription price. So we know we got that other price, the price of illicit, we have to account for. I'm going to hold that constant in drawing the picture. Now, if the person were just purchasing through prescriptions, it'd be pretty simple, just a downward sloping demand curve. This kind of thing I showed already, also in a blue color in a previous slide. If they were just purchasing illicit, well, that would be a vertical line in this picture because they're purchasing illicit, the prescription price is not relevant to them. That's just a vertical line according to whatever illicit price I'm dealing with here in this picture, which I'm holding constant. What's interesting is when the prescription price changes, that can cause people to shift. As you move up that prescription demand curve, up and to the left, the illicit quantity, QC, becomes more attractive. And so you get people jumping from the left-hand blue curve to the right-hand vertical line. And so if you look in the aggregate, not everyone's going to jump at the same time. Maybe they have different fixed costs, or maybe their prescription costs are a little different between each other. But if you look in the aggregate, what you get is kind of a Laffer curve. And I've drawn that in light blue. At the low prescription prices, pretty much everyone who's buying opioids is buying it through prescriptions. So it kind of looks like the prescription demand curve. At the very high prescription prices, no one's buying from prescriptions, so you're on the illicit demand curve. And then you have the curve in between. So you get a range in which increasing prescription prices reduces demand, kind of the familiar law of demand works out fine, but then you get this other part of the Laffer curve toward the top where increasing prescription prices reduces the aggregate.
Wait, can you repeat the intuition of why you drew the illicit one vertical?
Well, this picture only has one illicit price.
I see.
So if I were to draw another picture where illicit price, then it would have the slope that you're looking for. And we're going to do different experiments here. Some time periods and some comparisons, the illicit price will be fairly constant, and the prescription price would be changing, like with these regulations. Regulations go toward the prescriptions. On the other hand, well, other cases like those last couple of years I showed you with the factor of 3, where the illicit price will change and maybe the prescription price not changing as much. That would be a different picture. Okay, so now I'm going to just look at aggregates. Because remember what I showed you, that illicit opioids have gotten very cheap in the last couple of years, factor of 3 or 4 drop. Before that drop happened, mainly prescriptions was the choice for people. So the aggregate demand curve probably looked something like this. Because illicit opioids hadn't quite gotten so cheap as they are now. Now, I showed you there was an earlier area where they were even more expensive. But around the early 2000s, illicit opioids were fairly expensive. And it wasn't the choice for many people. But then over time, and this goes to your question, if we change the illicit price, then we get a different light blue curve. As the illicit's getting cheaper, we're going more toward that Laffer type of curve. So this is my view of what's happened over time, based on some of that data I've shown you. And so reducing illicit prices caused people to buy more opioids. Not a surprise. Now let me show you a little bit about race. This picture is, again, horizontal axis is year, and the vertical axis is deaths from opioids on a per capita basis, more precisely per 100,000 people. So of course there are more whites in the United States than there are people that are black or African American, but I've adjusted for the population sizes here. And you can see that deaths from opioids over this period were rising a lot for whites. They're fairly similar in the beginning, but by the end of the period I've shown you here, they were about double, if not more than double, for whites than for blacks. And Deaton and Case published a book not that long ago, but they worked on the book. All of you who have written books, you know it takes a while to write the book. Then the book finally comes out. When they were writing it, this is basically the data that they had. And so they have at least a chapter in the book trying to explain why is it that the opioid epidemic's mainly a white person thing. And they talk about culture and stuff like that. My advice would be that they might have looked a little bit more at prices. Because the same model I'm going to show you would say that, yeah, during this early phase, the whites should be consuming more opioids. Presumably, they're consuming more, also dying more from opioids. But that is actually a situation that's about to reverse itself. And if you look through in the next few years, you'll see these two curves cross each other. So let me show you first theoretically how it works. So go back to that early demand curve for versus prescription price. And the whites and blacks are going to be at a different point there, because the blacks have a somewhat higher prescription price. Now, why is that? This is something, before I got into this issue, this is something that's been discussed. Well, blacks have a tougher time getting prescriptions, maybe for a lot of types of pills. More likely to be uninsured, for example, so it'd be more expensive. There's also been discussion about whether we had a talk earlier about the prescribers. Maybe the prescribers treat people different by race, or maybe they're going to a different type of doctor. The type of doctor matters, as you showed. So these are factors, but bottom line for my purposes, prescription price somewhat higher for blacks than for whites. Got it. But now remember what I showed you happens over time. Over time, we get this demand curve kind of flopping over into the Laffer curve shape. So look what happens to the blacks versus the whites. The blacks start out behind, if I can call it behind when you're dying less from opioids, but at a lower quantity, and then they end up at a higher quantity. So the same idea, I'm economized idea, I got one idea, but I've now said two things with it. One thing I said is that raising the price of prescriptions can actually have more opioid use. The second thing I'm saying to you about that is, same idea is that it can cause the group that was behind to be ahead. And now I don't care what behind and ahead mean here. They're just switching ranks. Another way you might put it is, in a sense, because the whites have easier access to these prescriptions, which are more expensive, they're kind of more protected by the prescriptions than the whites are. But anyway, we see in this picture that the roles would reverse. It's not often you have a theory that says, usually a lot of times we have theories, well, let's explain why this group is behind that group. Like, we've had theories like, why did women earn less than men? And then, well, women tend to catch up with men. Yeah, but this is going more than that. It's saying blacks are not just going to catch up to the whites. They're not going to converge with them. They're going to pass them up. It's a pretty radical prediction. Another way to see it, think of it algebraically, forget about big picture, just algebraically say, how much opioids is somebody consuming, a group consuming? Well, it depends on these two prices, the prescription price and the illicit price. If we're in a situation where the prescription price is increasing opioid consumption, and there are a number of studies who found that, they found that around 2010 or so, when states started to, and also the federal government, started to crack down and make it harder to get prescription opioids, they found people switching to heroin and dying at least as much, if not more. So if you're in a range where that first price kind of has the wrong sign, then you have to conclude, just as a matter of logic, that any group that is different on that first price is going to be a rank switching group as the illicit price falls. Well, this is what happened. Between the time they were writing their book and the book got to come out, the blacks passed up the whites. And this is something that was predicted if you looked at it from a price perspective. Here is, I showed you two series before, blacks and whites. Now I want to show you a little bit more information, so I'm going to show you now the difference between blacks and whites. It's going to be the vertical distance between two curves like this. So this is blacks minus whites. A negative number means lower death rates for blacks, and a positive number means a higher death rate for black. And I've shown you, I'm not able to take this back as many years, but I've shown you here for all ages. And as you've already seen, blacks tended to be behind, lower death rates. And then their death rate starts to increase, catching up to the whites, and then by 2019, almost passing them. Even before COVID came along, you're like, yeah, the blacks are about to pass. Now I want to break this down by age, because the theory that I used, the one idea, says not only will the blacks pass the whites, but I can tell you which groups of blacks are going to pass which groups of whites. Remember, it had to do with the level of demand. We have an increase in return situation. Who's going to be the people who are going to be ready to use the illicit opioids? Has that fixed cost. It's going to be the people with the higher demand. They tend to be the older people. It's not like it's an old age thing to have lots of opioids, but as you've taken these drugs over time, you get tolerant and you need more to get the same feeling. So here's old versus young. You can see if you look at older people, age 45 plus, they had already passed, among already age 45 plus people, blacks had already passed whites by 2015 or 2016. And the young, still, latest data I have, the young blacks have not yet passed the young whites. And that's exactly how you expect it to line up in the increasing returns type of picture. Okay, now we want to, the third thing I promised to show was the what increasing returns has to say about old versus young. So I kind of mentioned, well, old and young may be similar in a lot of ways, but the older are going to have higher demand level. And I'm going to break it down here. I've called old and young. I'm going to show you some things where really youth would be a better word, and adults. Adults meaning 18 and older, youth meaning 17 years and younger. So what's going to happen over time with these price changes we've looked at with these different groups? Well, the prescription crackdown, it's going to increase. That applies to everyone. These regulations on prescriptions are not like, oh, older people are exempt from those regulations. They apply to everyone. For the younger people, that'll cause them to consume less. But the older people might be at a high enough demand level that switching makes sense for them. And so they end up consuming more. Both face the same price increase, but one reacts by consuming more, the other reacts by consuming less. And this is kind of what we see in the data. Here I am showing you adults versus youth separately. The adults are the black series. The youth are the blue one. Now, youth I rescaled. The death rates for youth are much lower. They use lesser amounts. Younger people don't yet have health problems that make them vulnerable. You know, your younger people aren't going to have a heart attack or something like that. So I've rescaled to put them, to draw these next to each other. That's why I have the standard error bars on I'm using death certificates data for almost all these pictures. And there's something like 3 million deaths a year. There's a lot of deaths. The standard errors are teeny tiny, typically. But for the youth, the deaths are rare enough that the standard errors are maybe not so trivial, so I've drawn them in here. Then around 2010, you start to get the crackdowns in the regulations on prescription, making it harder to get a prescription. And that's when you see the adults' death rate continue marching up, whereas the youth one actually goes down. Now, these prescription regulations were, the whole intent was, and I take the people at their word, the whole intent of the regulations is to reduce deaths from opioids. Didn't work for the adults, but it did work for the youth. Now, maybe someday the hope would be, well, we had a whole generation of youth where it's hard to get prescriptions, so they didn't kind of get hooked on opioids, and then when they're older, they don't need to move to the other thing. That could be a long-run effect. But in the short run, the only group that you can see where these regulations actually pushed in the direction of lower death rates was young people. Even young adults, you can't see an effect, but for the youth, you can. You can see they were going up kind of with everybody else, and then around 2010, they started coming down.
And Just to be
Yeah.
clear, 2020 there is just COVID related. There's no other reason for that big jump in the police.
Yeah, that is COVID. Another argument I had with Case and Deaton is they said, don't worry, stay at home won't make an opioid problem.
No despair with that. No despair.
And I'm like, no, it depends on the prices. Depends on the prices. And I think a pandemic's gonna, if nothing else, is gonna change prices of a lot of things a lot. And very much lower the price in the broad sense of using opioids.
Well, the price of the other goods went to almost infinite relative to the opioid price. A lot of those other goods were no longer
Yeah,
available.
that's part of it. Your time. I mean,
Getting a doctor for a prescription is impossible. The cost of the legal market went up tremendously.
the other
The corner was still there.
the other part is these are serious drugs. I mean, they're killing people, right? I mean, this is not. Winston Churchill was a functioning alcoholic, right? We probably had some presidents who were functioning alcoholics. There are some drugs that you can take and kind of do your job. And maybe Winston Churchill did his job quite well, okay? These are drugs that you can't do your job quite well, okay? So it doesn't mix with employment. It mixes with non-employment. And we were paying people big time to be not working. So you've actually lowered these unemployment payments lowered the price of taking opioids. Because one of the prices of taking opioids is you're not going to be able to maintain your job. Well, now you're paid not to maintain your job, so why not take the opioids? And that's another paper we could talk about, but you can see when the money, in the months when the money arrives from the stimulus, is when the more death certificates pile up. What else can I say? So that's COVID related, but I think my point being is price. Price. Okay, so,
There's a question.
yeah,
I mean,
yeah.
I think I was going to ask later, but I think it may be related. There's a third market that I don't know if you have a notion of how big it is, which is there must be a black market for prescription
Yeah.
opiates as well. That maybe because the blue uptick in COVID is the teenagers. So maybe I don't know if that price it somehow became easier to steal it from
No, it's the
home cabinet or.
no the youth here, and you're right, they're teenagers. Thankfully, there's not many 9-year-olds dying from this,
Yeah, I mean, I was.
but there are plenty of 13-year-olds. I'm afraid the teenagers, no, they're dying from illicit fentanyl,
Okay.
like the adults are.
Because I mean, I also thought about it with the ratio that there must be a black market for that prescription.
Yes.
But I don't know how much it reduces the price.
Yeah, there is a black market now. The supply tends to be similar. So one of the things when they're cracking down on prescriptions, it becomes harder to get prescriptions in the black market as well, because it's coming through that pharmacy channel. Ultimately, it went through, a major pharmaceutical company and went through a legitimate pharmacy. And then it may change hands after that, but it has to kind of go through that channel. So that price can be pretty important. And you raise the price at the pharmacy, you're going to raise it in that secondhand market. There's another study, a couple studies that have looked at when Medicare rolled out. Remember that Medicare is the government paying for the pills. And what they did is they said, well, some regions of the country, some counties and things like that, they didn't have many old people, so there weren't many pills rolling out in that area. And other parts of the country had a lot of old people, so there were a lot of pills rolling out. And they found that the people who aren't elderly were more likely to die from opioids if they lived in an area where a lot of old people were. And so you really have this pharmacy price feeding into the secondary market. And you would find, is it a market that they buy? You would find, a 28-year-old guy with a prescription in his pocket. It doesn't have his name on it. It's one thing I wasn't allowed to talk at the White House, that grandmas were drug dealers. Because it's true, most grandmas are not drug dealers, but there were a few grandmas who were dealing in a very large quantity. Too many sad stories I could tell you this, Ted. This was predictable. This was predictable. That's one reason Medicare drug program is different than the medical hospital program, because it's really hard to resell your hospital bed. Medicare bought you a hospital bed, try reselling it. Not easy. But reselling a bottle of pills, much easier. And it was sad that we didn't really look at that when we passed that law. Not only did we not look at it, the government, when it set up the whole program, didn't have any system for monitoring. Like, oh, we're giving away this product that's very easy to resell. Should we maybe check and see if it's happening? Nope, not allowed. And that made a big difference. So I'm getting off track, although it's all about prices, so it's okay. Okay, so what happened, I view this as a fairly stable demand system. So in that sense, I'm the opposite of Case and Deaton, where they think there's like a whole sociological thing determining the demand, and that's changing over time. I think we have a stable demand system. Doesn't mean everyone's identical. You have some people in a sad situation and they don't have a normal upbringing, but they have a demand curve, and that demand curve for those people in that situation is not any different 20 years ago than it is now. What's different is the prices. And at first, the prescription prices declined when you had, especially the Medicare program, come in, and then you had the illicit prices declining in that second phase that I showed you. And I think this explains a lot of the increased consumption of opioids and ultimately the deaths from opioids, and also the incidence, by which I mean which groups are more effective than others. So the kind of last part that I left out, why did the prices fall? And I give away some of this. Prescriptions has got to do with Medicare. Part D is the new part of Medicare they created in 2006 to cover pills. What about the illicit prices? What's going on there? A couple things. One thing is, and maybe it's the most important, it's the synthetic revolution, which we had in other areas maybe before our lifetime, but in a lot of areas like clothing. Used to be clothing came from the sheep and things like that. You would have an agricultural industry, and you need land and stuff like that, and you take care of the sheep, and then you shear the sheep and make it into wool and make it into a pair of pants, right? About in the 1960s, they began to figure out, we can make pants in a factory without ever really consulting the sheep, and become much cheaper. You can produce on a mass scale. And the supply curve really becomes quite horizontal. I mean, it's basically made out of petroleum, and so if you make more pants, no big deal. You're not going to affect the price of pants. You're just taking a little bit of oil that people can't use in a car or somewhere else where they would use petroleum. We've seen that in food. The synthetic revolution happened in a lot of areas, and every time we figure out how to take something we used to make on a farm and learn how to make it in a factory, it got a lot cheaper. Well, opioids had its turn in the last decade or less. Now, scientists have known how to make opioids in a factory for years. Fentanyl's been around since the 60s. If any of you have anesthesia, you probably had fentanyl made in a factory. And it's very cheap, and that's one reason why fentanyl is so common for your anesthesia is it's very, very cheap. But the criminals learn how to make their own factories. How do they do that? Reading on the internet, sourcing ingredients, especially from China and India. And so now the criminals are operating factories, and now they can make opioids. They've basically driven heroin out of business. Heroin's, it's on a farm, the poppy plant. There's also a kind of factory phase. After the poppy plant, you go into factory phase. So they call it something like semi-synthetic. But the fentanyl is purely made in a factory. And they can make now massive, massive quantities. Also, some other drugs have gone in this direction, like meth. That's another. So meth has gone through the synthetic revolution, so they can make massive, massive quantities. In fact, I don't even think they know how to make a small quantity of meth anymore. They can only make the massive quantities, driving down the price. So that's definitely part of it. Law enforcement, I think, is another part. Our law enforcement, fentanyl still in the United States, and I think every country in the world ever heard of illicit fentanyl, it's illegal. You're not allowed to be making fentanyl, possessing fentanyl anywhere except in the hospital for that legitimate use. And our law enforcement policies changed around that. So let me give you a little history on that. Fentanyl, you've seen, heroin's older agricultural product, as I said, but there were times where in the heroin market, fentanyl would show up. Now, there was always some doctors who became addicted to their own fentanyl. Your anesthesiologist, maybe not your anesthesiologist, but an anesthesiologist maybe got into a habit. And so you had a few deaths from fentanyl even 30 years ago. But that would be the situation. Fairly rare sort of thing. But illicit fentanyl, there started to be people figuring out how to make it at home out of chemicals. And what would happen is some guy would figure out how to make it at home, make it out of chemicals, can make massive quantities compared to the heroin, and it starts getting out into the illegal market in his neighborhood, his county, or whatever. And the drug enforcement agencies, FBI, places like that, they start to get a few death certificates, and they would track it down. They find the guy, and they put the guy in jail, shut down his kitchen factory, whatever. So that was the pattern. It would pop up for a month or two, cops would chase it down, shut it down, done deal. Okay, then in 2014, fentanyl pops up again, but now it doesn't go away. And what happened? Well, in August 2013, the Attorney General of the United States said, hey, drug crimes are nonviolent crimes. We're not prosecuting those anymore. And of course, government officials, they say stuff and they don't do it, right? But Attorney General said, hey, I'm not going to be one of those type of people. You can judge me. Here's the metric I want you to judge me on, America. The federal prison population. If the federal prison population goes down, I've done my job. And you look at the federal prison population, it went down. It went up 33 years in a row before he said this. And then it went down ever since. So it seems like he did what he said, which is he's not going to prosecute drug crimes anymore. That fentanyl popped up in very end of the year of 2013. I don't know what you want to call it, January 2014 or December 2013. Popped up. America never beat it back. Sweden also, within a few days of when it popped up here, it popped up in Sweden. Basically, the ingredients, not just the ingredients, it was made in China, and China was shipping it here, and they were shipping it also to Sweden. Sweden police did not have that attitude. They said, this is illegal, we're going to chase it down, find out who's making it, who's distributing it, put them in jail, end of the story. Sweden followed a very different path. Fentanyl has had its time coming back in Sweden. It's kind of the cat and mouse game that we had for years. Sweden has it, but it was not a permanent fixture, but it became a permanent fixture here. And that made for a lot cheaper opioids, so I think that's the story. It's a government-centered story. Now Attorney General Holder was a Democrat, but guess what? Medicare Part D was Republican program. So I worked in the government. I can tell you no one in the government wants to talk about this. Neither the Democrats nor the Republicans. But they both contributed very much to making opioids cheaper. And we economists, once we understand that they got cheaper, we economists say, well, people are going to consume more. And it's about that simple. So, good. A little bit morbid topic. But economics works for everything. So, thank you guys. Any questions, comments?
Yes, I have a question. One comment. I said, oh, that's COVID. That's COVID policy shit. It's not the virus that caused people to take more drugs. It's what we did. It's just, we always say that's COVID, but no. Our overreaction to the flu killed a lot of people.
Well, there's some data that back up what you're saying. So let me say alcohol. The price of alcohol also changed. I think it has to do with being at home. We're going to go out to a restaurant tonight, right? The booze is expensive at the restaurant compared to home. It's about a 3x difference, almost like the fentanyl, but it's a coincidence. It's about a 3x cheaper to consume alcohol at home. So a lot of people were saying, oh yeah, bars and restaurants are closed, people won't have an alcoholism problem. From an economic point of view, no, you're cutting the price by 3x. Again, it's one of these things, you're making people worse off. They would rather go to the bar and restaurant where it costs 3x more and be with their friends and all that, but they're going to drink less. And we made them drink more. Now I say we, that's pretty much the whole world, except maybe Sweden. And you see alcohol deaths going up pretty much everywhere in Europe. Italy, England, everywhere. The opioids, really it's just Canada and United States is the only places I've seen. And I think that has to do with the fentanyl. Would be part of it. Another part of it is the bonuses. So we had, you remember our bonus? We had 600, this is time this way. We had $600 bonus, remember that? And then Trump shut it off, then it was zero. And then we had a $300 bonus, and then it got eventually shut off. And different in the blue and the red states. So it was like an M, kind of like the golden arches. When you look at the US deaths from opioids, golden arches, at the same time. Now Canada also had $600 or so, 500 Canadian dollars, I don't know exact difference, but a massive bonus. Theirs wasn't arches, it was just up and over. And guess what happens to the opioid deaths? Up and over. So I'm agreeing with you, I'm just putting some data to back up to COVID policies. The other thing that we knew, there have been studies, not many people paid attention. What happens when the government checks arrive? There's more death on the day the government checks arrive. This is not a new thing to discover. But boy, did I get yelled at when I was saying in March and April 2020, I said, like, you know, people are probably going to die. This is very disruptive. You know, they're going to be flushing money with nothing to do. And people were very angry with me. But this is a pattern we'd seen before. So yeah, it's COVID. You're right to call it COVID policy. It's not the virus that brought the people down. Yeah.
Yeah, I'd just like to, I guess, comment too, mention one of my favorite examples of this both the check effect that you described, which they call it some of the substance abuse literature. But my favorite example of the price effect is, for those who don't know, we talked earlier about SSI and SSDI. From 1972 to 1996, addiction to drugs and alcohol was considered a disability by the government. So the price effect of being addicted to drugs was not positive or reduced; it was negative. Consuming more drugs actually got you more income if you could prove to a government doctor that you were addicted, and proving that you weren't addicted ended the checks. And so, not surprisingly, there was a bunch of research at the time that showed increased drug addiction, obviously from the program. And after it stopped in 1996, you did see a reduction in those deaths among disability recipients. But one of my favorite terrible government programs.
That's interesting. I hadn't looked a lot at that period because the death certificate data kind of became a different category, different quality in '99.
Yeah.
But these things still happened before, for
Yeah,
sure.
and there was a great NPR paper. I'm not sure where it was ever finally published, but the effects after the Congress cut it off in 1996. It's pretty stunning.
You had some questions in the back row. So start in the corner. Yeah.
Okay, so what would you necessarily suggest then to avoid kind of like the flush from cash myth? Because, you know, in the beginning stages of the pandemic, you know, we really didn't know what was going on, right? And so people were just being cautious. So what would you have suggested then to avoid the spike in deaths associated with just giving a bunch of cash to someone to meet their needs?
Okay, great question. It's actually multiple questions. So we had a whole bunch of non-COVID deaths spike in April. Drugs weren't one of them. Drugs spike in May. Guess when the checks arrived? May. April we were staying home. Alcohol spikes, so did a bunch of other things, heart attacks, stuff like that. So I think the checks are miraculously linked to the drugs part of it. We didn't need to be giving people more money than they're used to having. I mean, disruption is not good. We knew that we had these problems before. Opioid epidemic is not new. Deaton and Case wrote their book without ever being in COVID. It's not a new thing. Is a vulnerability in our population. Diabetes, we have a variety of conditions that were health problems. The number one thing I would have recommended is don't disrupt. If you got to disrupt, monitor. You knew you have these vulnerable populations. Keep an eye on them to see if your disruptive thing is actually backfiring on you. Nobody checking this stuff. I tried to send this stuff to journals in November of 2020 when I started to have little pieces of evidence. Like, no, they don't want to see it. Didn't fit the narrative. But you really should have been monitoring all these kind of conditions. But it was very politicized, I guess, and we couldn't do that. So, number one, don't disrupt. Number two, and $600 bonuses is disruptive. Think of yourself, you got it. You're not as old as me, but imagine when you're my age, and maybe you have some children who are nearing adulthood who might have these challenges. You know, one of the ways as a family, you try to figure it out and it's not perfect, but you try to figure it out and mitigate the problem. And then the government comes in and like totally disrupts your situation. You're not used to your 21-year-old son having thousands of dollars in his pocket. You're already kind of dealt with the situation in an imperfect way, but it was your best. And now you throw this wrinkle in. How am I going to control my kid who's got thousands of dollars in his pocket that he never had before? This was very disruptive. Yeah, and next you.
So I've seen a lot of blame for opioid deaths placed on like the large pharmaceutical companies for actually promoting a drug that they knew had these problems. Do you think that without the government perpetuating this, we would still have such a large problem like in the U.S. and Canada? Or do you think that it was started by the big pharmaceutical companies and then just kind of like the fires were flamed by the government policy? Or is there like something that, another scenario that I'm not listening to?
Well, yeah, when I worked in the government, as I said, Democrats and Republicans didn't want to take the log out of their own eye. So what are you going to do? Well, first you can ignore the problem. So in the Obama administration, the opioid epidemic was just completely ignored. So that's the first thing. But then the population's getting so upset that they're not going to let you ignore it anymore. So what are you going to do? Blame the companies. It was a favorite pastime. Love to trash the companies. And companies may have some, it's not my expertise, they may have some role in this. Even if they are to blame, like from the government point of view, we can't control the companies. We love to control the companies, but we can't. We can control the government in principle. In practice, we can't do that either. But I always say in these meetings, like, look, can we just look at ourselves? Can we just, if we can find a mistake that we're making, we can fix our mistake? But no. It ruined too many careers and reputations of government people, so we couldn't do it. Now, one story that's been told in court, doesn't make it correct, is that, well, the pharmaceutical companies got people hooked on pills. And then, once they were hooked on pills, they switched over to these other things. Okay, maybe that story works for whites. Look at the blacks. They weren't hooked on pills. So for whatever reason, the companies did not have great access to the blacks, but now the blacks are the leading. So I have a lot of trouble. I can concoct a story that a lot of indirect links that somehow leads the blacks to die in the year 2021 from things that companies did in 1999 to whites, but it's quite a stretch. Yeah.
You already mentioned about the incentive of government to do anything about the prices falling, but if that was not the case, I was just curious if price floors would be a solution to something like this, or would it just make things worse?
Well, you don't need to go have a price floor. This is a tough question on the prescription side. It's a little tough question because now we're in a phase where actually cheaper prescriptions actually save lives, right? In that earlier phase, maybe it would have made sense for Medicare not to be paying for this stuff. There were some drugs that Medicare didn't pay for, but opioids wasn't one of them. If they were going to be paying for it, maybe they should have been keeping an eye on what's going on. In the later phases, it's a tougher question. Maybe the prescriptions is the lesser of the two evils. It's the illicit market that's a real driver in this later period. How are you going to make the illicit more expensive? I mean, Sweden uses law enforcement. Law enforcement has its own problems. There's a reason why Attorney General Holder did what he did. Although I don't think he was aware what was going to happen next. But yeah, good questions. There was some other here. Yeah.
I mean, it was related to the pharmaceutical company story, because so in the end, even if that is the case, the government vetted the drugs as not as addictive as they were actually were. So and maybe that's why Medicaid was paying for the pills, because for some reason they either did not assess how addictive they were very well, or there was just corruption. But it's not like, I mean, they still have a role on that side. They can assess if this drug is like highly addictive. We're not going to pay for it just at that easily.
Yeah.
Which I think it's part of the.
No doubt that Medicare, when Medicare Part D started, there were drugs that they were not included.
Because they're highly addictive.
Yeah, they were prone to abuse.
Right.
They definitely were. Now, Obamacare required that those be covered, and still to this day, Obamacare requires. But once upon a time, there were drugs that weren't covered. There's a lot of back and forth between the industry and the government, but very early in the prescription phase, the government said we need to treat people's pain. And the doctor can't second guess. So if somebody comes in the doctor's office and says, I'm hurting, give me the pills. You can't say, you don't look like you're hurting. No. The patient is king. You don't question their pain. And that became a government policy in the sense that hospitals could lose money if the government didn't feel that they were following that approach to prescribing. So there was real money involved, especially for hospitals. In fact, the hospitals figured out, the government put in a survey, Obamacare had parts of this, put in a survey. Every time somebody leaves a hospital, we're giving them a survey. How was your visit and stuff like that. And there were questions on there like, did they treat your pain well? And the hospital started to realize, if I give them a really big bottle of opioids, send them home, they're going to check excellent service on that question, and then the government's going to give us more money. I mean, the doctors knew this, and they explained. We understood it was kind of gross and everything, but that's our business. The government's our cash cow, so that's what we did. There's no doubt. And we tried to fix this in the Trump administration. We did fix it, but we tried, and boy, was it hard. We just said, let's get rid of that program where the hospital gets more money when you
Give you the drugs.
And the Center for Medicaid and Medicaid Services, which runs Medicare and Medicaid, they fought tooth and nail. And if you look in the Federal Register, even when we passed the rule to stop this nonsense, they said there's no evidence to see that financial incentives affect opioid prescribing. And they were just fighting to the very end. The government will not. It was actually Chris Christie who did that. I'm pointing that out because he wasn't in the government. It was and ultimately Trump told him we had to do this, but it was Chris Christie kind of pushing from the outside. It wasn't someone from within the government saying, "Oh, we realize we made this mistake. Let's fix it." It had to be imposed by Trump himself. Yeah.
Do you get a sense of how much opioid initiations happen in hospital versus the outpatient setting? And were there similar, I guess you call them quality controls in outpatient settings? Because I thought the outpatient was a bigger deal than the hospital, but I wonder if I'm misinformed about that.
Well, no, you had some of these pill mills. So you had, some of these outpatient were dealing in millions of pills, even though they located in a town with a few tens of thousands of people. And they were not getting the hospital money. Now, you asked when people initiated it and things like that, so maybe they were in the hospital and they got a big bottle of pills, then they got addicted, and then they went to the pill mill. That, I don't know, has been sorted out, the kind of life cycle of that. Yeah.
Do you have any sense of how much of the increase in deaths is people intentionally taking more of what I call black market fentanyl and overdosing versus just the variability in dosing that you get with fentanyl because it's harder to take the correct amount?
It's become very fashionable to say that people who die from fentanyl didn't know they were getting it. We live in a big country. Definitely that happens. How common is it? I'm not so sure. I mean, you have areas of the country where you have zero heroin. The stuff grown on the farm just can't compete with the fentanyl anymore. And so for me to hear that, oh, somebody in New Hampshire thought they were buying heroin, what do you mean? There hasn't been heroin in your state for 5 years. So, and the other thing that you hear is that when somebody dies from fentanyl or heroin or whatever that's being marketed as, that actually causes more sales. Because then the people know it's a real thing. I mean, it's an illegal market, so, is the guy giving you some other chemical? Is he cutting it? Fentanyl is so cheap, they don't have to cut it. So I think the jury's out on that. And I'm a little skeptical. I think these stories are given too much weight. They're real, but I think you're given too much weight. Yeah.
A related question, and again, going back to Deacon's book, they call death and despair not only the overdoses, but also other types of, I think suicide comes in that, and I'm sure there's a lot of correlation the way we measure one and the other. And is the same evidence here of the switch? Because they focus a lot on this sort of like poor white population, on this epicenter of this death and despair, right? Here is showing at least one component of the split that has happened. Is there any evidence from the other?
Yeah, I don't know. I should look at that. I don't know. Alcohol and suicide is the other two categories. I don't know what the race gaps were before. There's not a literature trying to explain the race gap from before, so maybe it means there wasn't one, but I'm inferring a lot there. It'd be good to look at. During the pandemic, as we mentioned, alcohol deaths went up a lot, which is really quite remarkable because it's not an acute. Fentanyl, you can talk about someone could just like take fentanyl, not know it, and they're dead, right? Alcohol doesn't get you that way. Occasionally you have, the college freshmen who alcohol poisons, right? But most alcohol deaths are people whose liver was already weak from years of alcohol. And so it's remarkable that you had these alcohol deaths jump in April because it meant that the people who had an alcohol problem in their life went back. Suicides did not go up. As the CDC defines them, now some people want to say, well, maybe a drug death is a suicide, and it's hard to get into intent. But the death certificates show somewhat less suicides in the pandemic. But I don't know the race gap. It is knowable. So, good. Yes.
Question, or I guess maybe a comment about the race gap thing. Could it possibly be that, in the same sense that Black people were more likely to be uninsured and weren't getting the prescriptions for opioids, could it be the race gap was caused because, in the same sense that they didn't have insurance for prescriptions, they don't have insurance that may cover rehabilitation from opioid use? I guess is that a possibility or something?
Yeah, that seems
that
like
you
a
might have considered?
a possibility. I mean, treatment is, there's a whole interesting analysis that can be done on treatment. Treatment's become a growing industry, a lot. I don't know about there's probably literature, but I don't know what about it. Participation in treatment by race. I don't know. Yeah.
So this kind of relates to the first talk today where you talked about the many taxes that kind of forced families to request Medicare and Medicaid. So wouldn't like the African American community, like they would have those types of insurance that would allow them to access these same bills, right? So is that like, would that count like a small portion of some of the deaths? Like you're having some kind of baseline deaths of people who are Black with insurance that get hooked on these, or do you think that that would kind of make like them closer together? Where
I'm not sure I followed the question. Now the blacks, elderly blacks are part of Medicare just basically as much as elderly whites are.
yes, that's what.
So now that's a fairly old population to be involved in these drugs, although some of them are. Most of the action I showed you 45 plus. Most of the action there is in the 40s and 50s.
Okay.
The elderly's less. And the elderly are different. I can't remember exactly how it went down. The elderly are different than the people in the 40s and their 50s. Both the race gaps and the changes.
Okay. That was what I was asking. I just poorly worded it.
Good.
Well, thank you so
Thanks,
much.
guys.